Guys, after subscribing to this channel, please make sure that you also press the bell icon so that no notification, no new video of mine, any educational video, is missed by anybody.
All right. So I welcome one and all in this class tonight, and I'll try to clarify your concepts regarding endometrial carcinoma, though it's a very, very easy topic, like I was just telling in the introduction. Endometrial carcinoma happened to be the easiest carcinoma, not only to understand, but even to treat. And only in a year update, everything has changed. The staging of endometrial carcinoma has become far more complex than it was before. Nevertheless, in tonight's class, I'll make it very, very simple and easy for you, everybody, to understand and remember. The second thing being the molecular classification. Up until now, it was difficult even for me to understand exactly what do we do in molecular classification and how do we scan the reports. Patients were sending me the reports which were done, in cities which were like, Calcutta and Mumbai. And we have not yet taken up doing this, approach over here. So it was very difficult for me to understand what exactly should I give them as a prognosis. I just study, read, and give them. But now, in tonight's class, I'll make it very, very easy for you to understand. At the level of postgraduates, all that is required, that's going to be taught in the class tonight. So now, quickly in the chat box, I want an answer from everybody who's there in the class, since I've now started recording it, that you can see my slides and you can hear my voice absolutely clear. It is not breaking in between. Just quickly give me a thumbs up and I'll move further. Okay, so I have an okay amount of students over here, and I just want a thumbs up if you can see my slides properly and you can hear my voice without any breakage. Okay. Thank you, Geeta. Thank you, Usha. All my proactive students. Thank you. Now, like I said, there have been many advances in the understanding of the pathological and molecular features of endometrial carcinoma. And based on these things, the staging has drastically changed to endometrial carcinoma. You might have seen so many of my videos already there. I made the staging easier for everybody and I keep posting it on YouTube in between. But even for endometrial carcinoma, I did that. And I said in the very outset, it's the most easiest of all the staging to remember. But now things have changed. Nevertheless, I'll make it simpler for you anyway. So when we embark upon understanding the staging of carcinoma, the endometrial carcinoma, today I have a different scheme. Like I always give you a different way to remember every carcinoma. This time I have a different scheme for you. Okay, so let's begin. Now, I'm really sorry for this slide. It looks a little, a little dull, but that was last moment. I wanted to, include this slide as well. So I just took a picture and I just put it over here. This is the best, I got for your diagnostic test. See, what happens is that let's first take up the clinical features and then we'll make you understand the, diagnostic modalities. What happens to you basically is a patient comes into your OPD, okay, and the most common complaint of the female is a erratic bleeding cycle. Let's say very heavy menometrorrhagia we used to be taught before. Irregular cycles, heavy cycles, postmenopausal bleeding, something to do with vaginal bleeding, right? So most common presentation happens to be a erratic vaginal bleed. It's not the only postmenopausal females will have this, right? So it's not just only postmenopausal bleed, but postmenopausal bleed makes us one step further closer in understanding that it could be a possible endometrial carcinoma. In 80 to 90% of the patients, there's some problem with the vaginal bleeding. Obviously, the incidence of endometrial carcinoma is increasing around the world, and under the age of 40, you don't have much, but 40 years and above, you have very high predilection of getting into endometrial carcinoma with this kind of setting, like an obese female or a nulliparous female, or a female with one of those risk factors which I'll be elaborating in a couple of minutes to you. Obese female, diabetic female, these are all having high predilection into becoming candidates for endometrial carcinoma. And that being said, guys, can you tell me the high risk factors for, yes, that being said, the high risk factors for developing endometrial carcinoma in the age group. So this is the slide which was for the high risk group. I'm sure you have already got a hint, but let me quickly get an input from all my students here, just for a little bit of chatting with everybody. And all those students who are there on the channel right now, please somebody help them out to join this group. Jitu, Akash, whosoever is there right now with me in the class, can just post it on the channel. the link to join the chat group. Okay, so just post that message once again to all the students who are there in the channel proper, because I see a lot of students on the channel, but so many students cannot write on the chat. So please make sure that they're able to enter the chat box. So yeah, quickly, give me the risk factors for a female to develop endometrial carcinoma. I think I have already told you about nulliparity, I've told you about obesity, I've told you about diabetes. What else would it be? Okay, early menarche, late menopause, very good, very good. As much as the estrogen exposure she's getting and the less of progesterone she's getting, she has a high risk candidate for endometrial carcinoma. There's so many guys. I want everybody to give me at least one. Very good, Nazima. Absolutely. PCOS, Neelam, very good. Early menarche, yes. Obesity, yes, very good. HRT, yes. Why? See, not all HRT, but definitely HRT we're giving in hormones at a time when the nature has itself cut off the hormones. Okay, so we are unnecessarily giving exogenous, not, I wouldn't say unnecessarily, I would say that we're giving hormones to a female whose natural cycle has gotten rid of the hormones, probably that she does not need it to that level, or she does not need it exactly in that generic salt in which we are providing her from outside, as a result of which we bear the catastrophe of not only endometrial carcinoma, sometimes even breast carcinoma. So the reason of maybe yes, HRT could be a reason for endometrial carcinoma. What about tamoxifen, guys? That is given as a treatment for breast carcinoma, as a follow-up, as a medical chemotherapy for breast carcinoma. Tamoxifen is highly associated with not only endometrial hyperplasia but also with frank endometrial carcinoma if this endometrial hyperplasia is left unexplored. I think I spoke about endometrial hyperplasia in my last class, and we took up tamoxifen towards the last slide, if you remember. For an asymptomatic female, there's no limit, but if she's a symptomatic female, then what is the cutoff for doing the endometrial biopsy? 7 millimeters, right? All right, Lynch syndrome, very good, excellent, Neelam. This is what I was waiting for, the family history of Lynch syndrome. Can anybody quickly tell me what is Lynch syndrome? What all things are there in this Lynch syndrome? And it is an autosomal dominant variety, okay? So this is an autosomal variety in which you have colon cancer, you have endometrial carcinoma, sometimes even ovarian cancer, also associated along with this horrible syndrome, which is running in the family. So these are the risk factors. You have nulliparous females, you have infertile females. Yes, infertility we didn't talk, ART we did not talk, late menopause, early menarche, obesity we said, we covered HRT, we covered tamoxifen, we covered diabetes, certain ovarian tumors, remember you missed out on this as well, Lynch syndrome we covered, high-economic and endometrial hyperplasia. Now, suppose she is a high-risk candidate who comes to you with endometrial, with this vaginal bleeding. What's your next step? What is your next step? Your next step is to diagnose it, right? What if she comes to you, let's say, around 76 years of age, okay? You send her up for an ultrasound and it comes out to be atrophic endometrium. Can she still have endometrial carcinoma in the atrophic endometrium? Is it possible? Any answer from my intelligent students? Okay, very good. Very good. Answer is correct. But which kind of carcinoma can she have? Can she have an endometrial carcinoma, the one which we study about? Is she going to have that kind of carcinoma, or is it going to be a different variety? Very good. That being said, that's my next slide. Okay, so it's an estrogen dependent variety and an estrogen independent variety. So non-estrogen dependent and estrogen dependent. So the type 1 is what we've been talking about. It's like 80% of the times this is the carcinoma which we are following, and it's a very good carcinoma, right? Why? Because it responds to our medication. It has a very slow invasion rate and a good overall 5-year survival rate. Plus it, like I said, it responds to medicines, all right? So it's got a good prognosis. Vis-a-vis type 2, which is non-estrogen dependent. It's there in atrophic endometrium. It's poorly differentiated. Here is where it starts. It's poorly differentiated. It's usually the serous variety and clear cell histology. So that's what happens when you're doing the curettage. You send it for histopathological sampling. Comes out to be a serous endometrial carcinoma. That's not a very good prognosis. And it comes out to be endometrial carcinoma. Well, it's got a very good prognosis because it's a low grade. Endometrioid, when I say endometrioid endometrial carcinoma, you'll see many times me referring to EEC. EEC means endometrioid endometrial carcinoma, which is the usual carcinoma that we detect on histopathology. This is a histopathological diagnosis, guys. And every time when I talk about certain terms, I want to make sure what I'm and how did I get there. Okay, this was the most confusing part when I was at your age, understanding, how we reached there. What do you mean by endometrioid histology? That means you've taken, somebody had come to you with this complaint of erratic vaginal bleeding. You posted up her for a hysteroscopic guided biopsy. You sent up the endometrial sample for biopsy. It came out to be an endometrial carcinoma. So, as a result of which, what you're thinking is now that it's a low-grade endometrioid variety or a low-grade endometrial carcinoma, and it's a good carcinoma to begin with because it's got a good prognosis.